Examining the correlation between treatment effects in clinical trials and economic modeling. This presentation is based on our publication in the Expert Review of Pharmacoeconomics and Outcomes Research. I thank my co-authors. The outline of this presentation. Many chronic diseases have a pathway from first-line treatment to subsequent treatment. When two treatment effects are considered independent, the probability of success for the subsequent treatment is not impacted by the failure of the initial treatment. However, compared with new patients without any previous treatment, patients who fail initial treatment may have decreased success rates with a second treatment, even after controlling for various disease factors. STAR-D trial showed that remission rates for depression were 36.8%, 30.6%, 13.7%, and 13% for the first, second, third, and fourth acute treatment steps, respectively. When the same treatments for depression were used in different steps, remission rates with a prior treatment line were higher than those with a next treatment line. For instance, the remission rate was 25.5% when bupropion was used as step -2 treatment and only 6.7% if it was used as step 3 treatment. A similar phenomenon has also been observed for managing advanced non-small cell lung cancer and moderate to severe Crohn's disease. We will elaborate on these examples below. The phenomenon in the above examples can be explained by a correlation between treatment effects. However, the correlation between treatments has not been explicitly discussed in the literature. If initial and subsequent treatment responses are assumed to be independent, theoretically as the number of treatments increases, the probability will eventually increase to the point where all patients are successfully treated. We know that in many situations, such as depression, chronic wound, and resistant hypertension, this does not occur. If the correlation magnitude between the initial and subsequent treatment effects were known, then physicians would likely choose a subsequent treatment that either has no correlation or minimal correlation with the initial treatment. This way, patients would receive a subsequent treatment that works differently from the failed initial treatment and will likely achieve better outcomes. Borrowing ideas from Dendekuri's model, we propose a new approach to understand the correlations between treatment effects. There are one or more patient-level unobserved or unmeasured underlying covariates between treatment effects, such as unknown genetic variants. After controlling for these covariates, the residual correlation would be close to zero. For correlated treatments, these covariates can be used to interpret why the chance of success for a new treatment is lower for patients who have failed a previous treatment. Now, I will introduce the statistical model of covariance for the unobserved underlying correlation between treatments. The scenario for this model will be a chronic medical condition where no gold standard treatment has a success rate close to 100%. We assume that several treatment options can be used sequentially, conditional on failure of the earlier treatment. Thus, if a patient fails initial treatment, then they will switch to another option. We start with the theoretical concepts of correlation between treatments. For each patient, we consider two random variables, TA and TB, which represent the probability of success of each corresponding treatment. Both these random variables follow a Bernoulli distribution. We also assume that these random variables are correlated in a random way. For people with the random variable f equals 0, treatments A and B are independent, while for people with f equals 1, treatments A and B are positively correlated. In our article, we provide further details of the statistical model. The probabilities of all possible combinations of two correlated treatments are presented in Table 1. The probability of success or failure in both treatments is increased by an amount, compared with the independent case. it can be shown mathematically that the probability of one success and one failure is decreased by the same amount. This slide shows the magnitude of covariance. Let the minimal value of covariance be 0, which indicates that two treatments are uncorrelated. We also derived the upper bound of covariance because the probability of success for both treatments cannot be greater than the probability of either treatment being successful. Based on the table above, we obtain the overall probability of success of receiving initial treatment followed by subsequent treatment, and then we can derive the expression of covariance. We can also derive the conditional probability of the success of the second treatment, given the failure of the first treatment. The effect of a subsequent treatment is discounted by its correlation with the initial treatment. If there is a strong positive correlation between treatments, the subsequent treatment effect is greatly discounted. Let a population represent all the target patients with indications for treatment A and B. Let us draw n observations from this population for group 1 and provide treatments. Treatment A first, then treatment B if treatment A fails. For group 2, where we draw m observations from this population, where we provide the treatments in reverse order. Treatment B first, then treatment A if treatment B fails. The estimates of the overall probability of success from groups 1 and 2 would be approximately the same when m and n are large. Thus, we can use the samples in groups 1 and 2 to estimate PA, PB, PA', and PB'. We conducted a simulation study to examine the correlation between treatment effects. Here is the null hypothesis and alternative hypothesis of a clinical trial. The null hypothesis is that PA is equal to PA', and PB is equal to PB'. Or, equivalently, the null hypothesis is the covariance is equal to 0. I skip the details of the design and results of this simulation study in this presentation, but introduce our main findings. 1. Compared with independent cases, the correlation between treatments reduces the probability of success for the second treatment and the total probability of success in 2 treatment attempts. 2. The stronger the correlation, the smaller the chance of success for the second treatment. 3. The magnitude of correlation only impacts the probability of success for the second treatment and does not impact the probability of success for the initial treatment. Now, I will introduce to estimate the correlations from published data. We provide an example of approximating the magnitude of correlation of the objective responses between platinum-based chemotherapy and PD-1, PD-L1 inhibitors for patients with non-small cell lung cancer. Platinum-based chemotherapy is the classical first-line therapy for advanced non-small cell lung cancer. The objective response rate for platinum-based chemotherapy was 26.6%. PD-1, PD-L1 and newer therapies. A meta-analysis showed that the objective response rate of PD-1, PD-L1 for treatment-naive patients was 30.2%, which was significantly higher than that of patients previously treated with chemotherapy, 20.1%. If patients did not respond to initial chemotherapy and subsequently received PD-1, PD-L1, the cumulative response rate for the 2 treatments is approximately 41.4%. Based on this formula, the covariance between chemotherapy and PD-1, PD-L1 is equal to 0.074, indicating a considerable response rate decrease for PD-1, PD-L1 as second-line treatment due to the correlation, compared with PD-1, PD-L1 as first-line treatment. Furthermore, we provide an example of qualitatively evaluating the magnitude of correlations between initial and subsequent treatments. Anti-tumor necrosis factor alpha, TNF, agents are the traditional first-line biologic agents for the management of moderate to severe Crohn's disease. New biologic agents, such as vedolizumab and ustekinumab, have been used for treating moderate to severe Crohn's disease in recent years. A systematic review and meta-analysis that found that the pooled odds ratios of vedolizumab versus placebo for the induction of clinical remission was 2.68 as first-line therapy and 1.52 as second-line therapy. Compared with first-line therapy, the efficacy of vedolizumab as second-line therapy decreased considerably. Given this, it is possible there is a correlation between the treatment effects of vedolizumab and anti-TNF agents. The pooled odds ratios of ustekinumab versus placebo were 2.75 as first-line therapy and 2.66 as second-line therapy. Given the similar odds ratios of ustekinumab as first-line and second-line therapy, the correlation between the treatment effects of ustekinumab and anti-TNF agents is likely to be small or none. Thus, although both vedolizumab and ustekinumab have similar efficacy for biologic-naive patients, due to no correlation with anti-TNF agents, ustekinumab may provide a higher chance of remission than vedolizumab for the patients with prior exposure to anti-TNF agents or with unknown treatment history. In this section, we illustrate how to adjust for the correlation between treatment effects in a cost-utility analysis using the example of RTMS followed by ECT after RTMS failure for the management of treatment-resistant depression. ECT has been widely used to treat severe depression in patients who fail antidepressant medications and is considered as the standard treatment for these patients. RTMS is a less invasive procedure with fewer short-term side effects. In practice, stepped care pathways are recommended for treatment-resistant depression. Patients are first offered RTMS, and then ECT may be prescribed for those who do not respond, which represents a stepwise pathway from less to more invasive treatments. Published economic evaluations have compared ECT alone with RTMS followed by ECT. In those studies, the response and remission rates of ECT as the first-line or second-line treatment were assumed to be the same. A systematic review of clinical predictors for ECT found that medication failure in a current depressive episode was a robust predictor for treatment response. Therefore, it is possible that the response rate of ECT as second-line treatment after RTMS may be lower compared with its use as first-line treatment due to the correlations between treatment effects. Since no clinical studies evaluated the correlations, we considered 4 scenarios: independence, weak correlation, considerable correlation, and strong correlation. This table presents the model inputs including clinical parameters, costs, and health state utilities. You may notice that the acute response rates of ECT after RTMS decrease with the increase of correlations, from 60% for no correlation to 12% for strong correlation. This table presents the cost-utility analysis results. We can focus on the Cowley, which is linked with the effects of ECT after failure of RTMS. Under the assumption of no correlation between treatment effects, the RTMS followed by ECT strategy was associated with the highest estimate of Cowley, 0.69. When the correlation estimate was increased from weak to strong, the Cowley of the RTMS followed by ECT strategy decreased from 0.67 to 0.59. Consequently, the increment in Cowley decreased: no correlation, 0.06 Cowley, considerable correlation, 0 Cowley, and strong correlation, minus 0.04 Cowley. I will briefly introduce the concept of correlation between multiple treatments. We adapt the conditional dependence among multiple tests for correlations between 3 or more treatments, and provide the general correlation term, which is equal to the difference between the true joint probability and the joint probability under the independence assumption for treatments. In the supplementary materials of our article, we provide further details of the correlation terms and their applications. Finally, I will share some thoughts for future research. We can extend these correlation concepts for successful treatment response to adverse events, since correlations between specific types of adverse events for different treatments may exist as well. For example, treatments in the same class often share similar adverse events, stronger correlation, while treatments with different mechanisms of action may be associated with different types of adverse events, weak or no correlation. The correlation of treatment response and adverse events between treatments can be examined simultaneously in a single clinical trial. Future research should start with post-hoc analyses of previously completed clinical trials to examine the correlation between treatment effects, if information is available for sequential or historical treatments. Researchers also can incorporate the possible correlation between treatment effects in economic evaluations by modeling the pathway of sequential treatments. These efforts could help us better understand the correlation between treatment effects and its impact on cost-effectiveness results, and lead to more credible decisions when determining the proper treatments in a sequential treatment pathway. Here is the timeline of this article. Thank you.